20/228. I now give the floor to Mr. Midnight Poon Kasetratana, Executive Director of APCOM.
Mr. President, Excellencies, ladies and gentlemen, and fellow civil society participants from key populations and young key populations of gay men, other men who sex with men, sex workers, transgender people, drug users, and people living with HIV. What can I add from my corner of the world in this high-level meeting? I am Midnight, Professor Watanabe, Executive Director of APCOM. My coalition works in Asia Pacific, the region where a little over 60% of the world's population is there. And I wish to make the following statement in this meeting. If we want to achieve fast track to 1990 in the year 2020, the time is now for urgent and increased investments in innovative regional and national approaches and programs for and led by key populations, for them to break down structural barriers that affect and make them vulnerable to HIV, especially of young gay men and other men who have sex with men and transgender people in our region. So that's my statement. And I can hear many people thinking this is nothing new and that you are all aware of the situation and what needs to be done to end HIV in our lifetime. Wonderful. But then my question is, why I and other key populations here have to repeat ourselves in every high-level meeting and other regional meetings to make the same plea? As a proud gay man and member of the lesbian, gay, bisexual, transgender, and intersex LGBTI community, I echo other global and Asia-Pacific civil societies' disappointment at the 2016 declarations, which in our opinion is not as strong as the 2011 declarations. We are disappointed the language in key populations was not stronger in the declaration, as it repeatedly omits, excludes, and misrepresents the key populations of gay men, other men who sex with men, sex worker, people who use drugs, transgender people, as key populations affected by HIV worldwide. Not mentioning the most affected communities is turning a blind eye on the realities in the world and the realities of HIV and AIDS by excluding the very people here in this room from the HIV response weakens the key population's programming. Criminalization, discrimination, and stigmatization of gay men and other men who have sex with men increases vulnerability and making barriers to accessing the much-needed health services. Asia Pacific has more than 60% of the world's population. It has the largest epidemic outside of sub-Saharan Africa and was barely mentioned in the declaration. Asia has been experiencing a rapidly escalating epidemic among gay men and other men who have sex with men, with nearly 50% of new HIV transmission forecasted by the year 2020, in particular of the younger age groups. This was forecasted in the 2008 Commission on AIDS in Asia, and yet we see little political commitment. Let me give you some examples. Prevalence among men who have sex with men is more than 5% in countries like China, Indonesia, Malaysia, Myanmar, Thailand, and Vietnam. Particularly in cities, prevalence is higher, 15% to 31% in urban centers like Bangkok, Hanoi, and Jakarta. Only about half of men who have sex with men get tested for HIV. Access to condoms for low-income MSM is just 31%, and just less than 50% for high-income MSM. 90% of MSM in Asia Pacific do not have access to HIV prevention and care because of discriminatory laws. 18 out of 38 countries in our region criminalizes same-sex sexual behaviors. Spending for HIV prevention for MSM in the region is less than 7% of the total HIV budget. And to add, globally, transgender women are 50% more likely, more vulnerable to HIV. Another worrying trend in our region is the drastic financial assistance cut to Asia Pacific as countries transition out of international assistance. Even UN institutions that used to support APCOM has not been able to commit support financially for us this year. The trend does not look good and hurt the very people that we are trying to help. The fifth Global Fund replenishment is underway within a challenging environment to regain commitments from donor governments, and transitioning countries are experiencing grave difficulties with domestic financing. The required desired funding transition comes too quickly, too abruptly, and without proper planning, and in fact, destroying the carefully built-up investments in HIV infrastructure and the gains in combating the epidemic. Also, domestic financing accompanies the threat that governments will overlook and under-resource responses for community system strengthening, key populations, policy advocacy, and prevention services which are currently mostly funded through international resources. As we live today with the newly adopted 2016 declaration, I do hope that we all can utilize other opportunities to have a more progressive action and commitments on the ground to ensure equitable access to quality and non-discriminatory prevention, treatment, and care and support and services led and for key populations. Specifically, commit to naming key populations and young key populations, including gay men, other men who sex with men, sex workers, transgender people, and injected drug users. Commit to a roadmap towards removing policies on HIV-related travel restrictions and deportations, and criminalization of key populations and the LGBTI community. Commit to removing age restrictions, parental and marital consent requirements for adolescents and young people. Ensure universal access to comprehensive harm reduction, sexual and reproductive health and rights, HIV information services, and comprehensive sexuality education for all. Strengthen language on commitments to sustainable funding for civil society and meaningful community engagement. Commit to optimize the use of existing flexibilities under the TRIPS agreement, specifically geared to promoting access to and trade in medicines. Commit to the use of innovation and bring new technology to bridge and link prevention to treatment and care and support services, in particular on the use of pre-exposure prophylaxis for men who have sex with men, community-based and led HIV testing and HIV self-testing, for example, and using social media and online technology for service delivery. Last but not least, I request the member states to explore, develop, and maintain effective partnerships with key populations-led and serving community organizations. I believe that there should be strong commitments from the member states to engage communities as partners, leaders, and beneficiaries, including allocation of resources for community organizations, and support the role of community-led organizations in addition to service delivery. For example, in areas of policy and advocacy engagement, quality assurance, and community mobilization. We are, after all, your assets and citizens, and we are here with you, and that shows our strong commitment to ending AIDS. Thank you very much.